near future will be treating chronic hepatitis C without back in the from without recovery very soon.
Well, I could probably, make a response on this.
Yes, why not?
Actually, Roche, we're a pioneer in hepatitis, and we will be, and we're committed to be, because this is a disease area we think we could add value, we could make an impact. That's why, even though we made our franchise and based on Pegasus, interferon, based regimen, but we also look into R&D, we look into DAA. We actually have DAA in phase 2 and phase 3. And the only reason we started DAA because we know it's not good enough. And we are a company, we believe in innovation. We believe in bringing products that really add value and make an impact. If this is a product better, make a change in patients' life and the efficacy and safety, we will bring it to the market. If it's just another me too, we won't. In fact, we have a phase 3 DAA. We decided to stop the trial. But we have another, which is true. And we have another phase 1, phase 2 in the pipeline. And so I do believe, yes, pegylated interferon is not perfect for the patient. And we do believe, based on innovation and science, we could do better. And we want to bring in better products to the market. But I also, because I work for pharma, I know how pharmaceutical companies price the products. So that's just a word of caution. These wonderful safety, efficacy data, and also oral pills, and they come in a price. So it will be interesting to see how they bring in those products in the market and what price point they bring. And of course, when they bring in the products and affordable, then of course the pegylated interferon, the price will drop, right? So it's all about how much patient could afford and the value, the impact. And I'm very committed, once the DAA is available in the market, and if they're in a competitive price, then we will drop because, it's all about how much patient willing to pay and what effect, what outcome they could afford. So I think it is a complicated issue. And I think it's a combination of efficacy, safety, and also companies' decisions. But for us, we're committed to make our product available to the patient, and we're committed to bring better product to the physicians and to the patients.
Thank you, Ms. Ali, for your response. But as I have told you, when these drugs will be accepted, you have to go on the cost of the Pegasus, and you may not be having a very good profit. That's the economical side. We are talking about only on the patient side. Yeah. So if you don't mind, the size, that's it. I think you accept it.
Yes.
Yeah.
I think the price of Pegasus is something that we could improve, and we will. And I could assure you, Pegasus price, and with all the patient supporting programs, Pegasus treatment cost is the lowest in the Southeast Asian country.
Okay.
And if we can find any other country with a lower price, we will match it.
Okay.
And that's a commitment I'm willing to give to all the experts today here.
Okay, thank you for the comment. Now, excuse me, before adopting whether we should use the keys and everything, because the Professor Kamau elaborated on the findings of the years, so that he has put such an input into your brain. So we have to finally decide whether we should use it here or not. Now, before we on there, may I want Professor Tansit to stand about it? What about the hepatologists and gastroenterologists? Professor Tanaswi?
Thank you, Jay. I think it's still, to my opinion, it may be limited. I feel that it's still early to perform the larger leaders as well as the Europe or other trials. Thank you very much.
And your attitude is just wait and see what the DA is.
Maybe months or years.
For our guidelines to join.
Right.
Because package is quite expensive, and I don't know what to do the cost. I think it will be less costly, and we could pick it up. Not by thinking. Very me, would you like to make some comments? Yes.
So we must have at least first-hand experience. First-hand experience. First-hand experience.
Oh, that means you want to have the DA trial here.
No. Even we must have the drug available here, so that we can try and some ways and we have experience availability.
Okay. What you have mentioned is we should have our FDA clear the drug available and try it on occasions. Okay, we agree for it. But I don't know whether DA is being put up for FDA registration. Where is any? Okay. Would you like to say something?
Thank you very much. Our monarchs, our hepatology monarchs, our pharma monarchs, we have come up with facts and figures. And the future of hepatitis C brings with excitement. But for the meantime, especially for a country like ours, we have to make do with whatever is available.
Okay, now we have the good views of our liver specialists and cancer doctors. But we had two main general physicians. Professor?
That's a lot.
Wait,
Right, it's a lot.
Yes, sir.
can I ask you about your opinion?
Thank you very much, Mr. Chairman. Well, I'd like to thank, first of all, I'd like to thank Professor Kumawi for updating us with the current finding in the treatment of hepatitis C, which is very enlightening. However, I've also reviewed the available data myself here in the computer. And according to your presentation at the end of this study, I found that the many promising oral combinations are in phase 2. Phase 2. So, phase 2. Usually, my understanding is that usually after on phase 4, it is a widespread clinical application.
US FDA has approved
It is already approved.
Samaprevir and Sabotravir.
We should also take into consideration of this. FDA is not a joke. It's a very strong body, world-renowned body, which has, if it is approved by the world-renowned body, well, we need to pay great consideration to that decision.
Yes, thank you.
But on the other hand, being a country, developing country, we also need to strike the balance. On one hand, we should be updated. We should catch up with the world new developments. But on the other hand, we should also strike the balance of accessibility, feasibility, affordability, etc. So, my opinion, it is of my opinion that why we are, because we have already developed our own guidelines since 2009, we still need to make it available into availability community, and because this is the guideline development committee, updating committee, my opinion is that we should also take note of these new development in the new guideline, but with reservation.
Yes, I'll come to the
With
guideline
reservation.
in a few
Because-
minutes.
Yeah, and with the reservation.
Yes.
Because, as I have said, just mentioned, availability, affordability, feasibility, and accessibility, etc. So, we should adopt, we should mention, not adopt, we should mention the new development, new evidence in our new guidelines with reservation. This is my personal opinion.
Okay, thank you for your contribution. Well, the largest from Mandalay, Naomi, would you like to make some contribution or would you like to pass it over?
You should make a few comments. I have known the background, baseline data, what is going on currently in the field of treatment hepatitis B before jumping onto our development of NEMA new guideline to give you the baseline data. How would you comment upon that, like Mr. Chairman said?
Yes, thank you, Xian. Actually, the data should be based on the guidelines should be based on the MMR data. How successful
NEMA as well as
Myanmar
what's
as well
happening
as
in
what-
international
yes,
data.
yes, what's happening internationally. And for the actually we don't know the as we are rid of the genotype 1, 6, and 3, and so actually it's very difficult to change into the newer drugs which are not available at the moment. And we have only the hepatitis C, patients, well, I already gave you 44%, maybe in the CC, and which responds to drugs, pegylated interferon and ribavirin, with very good SPR rate. So we can treat these two drugs in genotype 1 until unless we are available with the newer DAs. Although the DA data are based only on the around 1,000 patients, I feel that it's a good enough because most of the pharmaceutical companies develop the drugs basing on the population around 2,000 to 10,000. They usually develop upon this, but these new RDA will not be available in the moment. So we cannot, I feel that we cannot wait for the moment. Whatever, we have to treat whatever available drugs here in our country. Who cannot wait for the newer treatment? But who has a very minimal fibrosis and who can afford it, so we can wait and see. We can wait and treat with the newer DA. But we don't know the price of the newer DA, which may be higher than these currently available two drugs regimen.
Before discussing about the price, you should discuss scientifically as a scientist.
As a scientist, I totally agree with you. The DAs are very good and it shows amazing results. So if it were in hand, we need not to argue about the usefulness of the DA. We have to recommend.
We have no slight, sorry, Mr. Chairperson. we have no slight doubt about the efficacy because you have presented it, you have learned it from TES earlier. And also there are evidences, we have no slight doubt, slight doubt about the efficacy. The only thing is that the applicability in our context,
That will come later
Yeah.
in the Myanmar guidelines.
Okay, thank you, Professor Nunsila. Well, we have talked about the opinions of the liver specialists, GI specialists, and whether with regard to the usage of DDE. But I think I need another opinion who is neither a liver specialist, nor a physician, but
A surgeon.
a surgeon who is interested not only our beautiful women of Allah, but also very interested in discussing for the possibility of using these in our country. Thank you.
Thank you very much for giving me the chance. Well, in fact, I'm not a hepatologist. I'm not a liver surgeon, but the only fact is that I was involved in the first 2 liver transplant in Myanmar in all the vascular
And all the 2 previous guidelines.
and on all the 2 previous guidelines. And with Professor Sonai in the successful result of the 2 liver transplant in Myanmar. But just my free opinion is that one thing is that Professor Kim Aung-Win, as I know him very well, I know him many years before you know him, and he is one man that he will always look for something new and something updated, and it is his habit and it is his hobby to share his knowledge. And he will invite and will keep on ringing telephones to come and listen to his talk, that how much he has spent time on preparing this talk and this sort of things. Well, I agree to him entirely. But like I'm in line with what Naomi and Professor Tillard has said. Now, it is that we always have to be updated. When someone says that antibiotics is necessary for patient in chronic syndrome, somebody's rejected it. Now it is a trend to have this to be given in a lot of coronary arteries, CCUs. It's something like that. So it is the duty of all the, clinicians who want to update it yourself to say things, keep on saying things that you have updated. But the only thing is that I'm very impressed with what Professor Wynn has said about the directly acting antivirals, and very impressive results in naive patients, like about almost 100% in one series.
The retreat
And
also.
it's a very interesting thing. But just to be now, after listening all these things, I'm very impressed. But only thing is, like Professor Lat and Professor Yumi has said, now we are now planning to make guidelines for Myanmar people, for which I think Professor Wynn is one person who has the most experience in using these interferons in our country, I would say, please excuse me if I'm wrong. And I would say that if we are going to make a guideline for Myanmar guidelines, and is it the right time for us to go ahead with what Professor Wynn has said, or to have that in mind and to keep it reserved for the future when it comes in, and when the time, something like the song of Eva, like I have a dream, and when the time comes, it will be on the scene. But for the time being, in a situation like this, we, as in our country, has to be careful in using the drugs, because we have our patients still very poor, and we have to make, when we use a drug, we have to make the drug which is most efficacious, you know, which has the most efficacy is at most. And at this time, in our guideline, I think it is the job of all the hepatologists here to decide whether it should be in the list or whether something, the proof of the pudding is in the eating, one has to be in the list, has to be in the mind. That is just what I would like to keep it in mind.
Okay, thank you, Professor Kamali, for a very elaborate and sincere suggestions. We're calling upon to draw the guideline for our country. What I would like to suggest is, you know, it is, I think, very embryonic stage for the DAEs to accept. I don't know, that's my personal feeling. Right. Now, we even tested the DAE in our country. Other people have tested it. But I have talked with the, if you compare with the PEG electron and the DAE, the cost will be a little lower, and the side effects will be lower. Now, we have come and concluded here to revise the guidelines for the hepatitis C. I think before going into detail, I think to go abreast with the other countries and the DAE, because FDA is only approved in America for the use of DAE. I think we should consider the usage of DAEs in the management of a chronic hepatitis C infection. But only after the pilot result, then I think we should have another meeting whether we could adopt it entirely, or we could refute it, or we should accept it for discussion or with some, yeah. So I think that's a message I want to give it to you. So Dr. Professor Win is going to present it. I'm not going to interpret. So when he is going to present it, I just want to have the words I have mentioned in your mind in the conclusion. Okay, Professor Win, the stage is up to you.